So we've arrived at the scene today to an unresponsive male. He's known to be 40 years old and fallen 6 metres off a roof. It was a witness fall, so we think the injury is purely going to be mechanical, but I can't rule out other causes. So he's AVPU, he's not alert, he doesn't respond to pain, he's still conscious, but he doesn't respond to pain or voice, but his breathing is irregular at the moment. GCS, we're making this up of 1 for eyes, 2 for voice, and 2 for motor, making it a GCS of 5 and a status 1. So secondary survey has revealed about 6 centimetre in diameter boggy patch on the back of his head in the occiput region. So currently we're going to be treating him for a TBI. Brody, would you please be able to do a full range of vitals for me?
Sure.
So TBI, the main treatment for paramedicine, we're just going to start with an OPA, measuring it from the mandible upwards. So we're going to maintain and secure the airway. Going to put a towel under his neck to keep that neutral alignment. And we're going to start with a non-rebreather mask on approximately 10 litres per minute. So our main aim for treatment pre-hospitally is to reduce the chance of secondary injury.
Okay, Ryan, so the vitals for you are heart rate of 50, blood pressure of 160/90, rest rate of 12 and irregular, BGL of 7.6 and a temperature of 37.
Thank you. So this patient's going to be a status 1. Would you be able to request backup and say we possibly need an RSI?
Okay, no worries.
So due to the blood pressure, the heart rate, and the blood pressure, heart rate, and the irregular rests, I'm considering that this has Cushing's triad, confirming the early stages of the TBI. So as I was saying, the main aim pre-hospitally for TBIs are to reduce the chance of secondary injury. So that we're treating hypoxia. We also want to monitor the rest rates for hyper and hypocarbia. And we also want to reduce the chance of the patient getting hypotension. In case of deterioration, we've secured an IV line. We're going to be considerate. We've got our fluids set up and ready to go, but we're not running them yet because of the blood pressure. Before we get the RSI in, we're going to want to get another IV bilaterally. Currently, we don't have a collar on this patient because his anxiety, he's a little bit agitated with that altered GCS. This is indicating his increase in intracranial pressure. So in order to combat that, we can also consider morphine administration, 1 to 5 milligrams, but at this stage, it's going to be okay.
Ryan, so RSI is 10 minutes away,
Yep.
and they've asked us to prepare for RSI.
Okay, so since the RSI is 10 minutes away, we're going to have to get this patient load and go, extricate, get him on the truck, get our checklist ready, and get all the equipment ready for backup for when they arrive. Right, so once we've extricated the patient into the back of the ambulance, we're not going to start moving yet. We're just going to start preparing this. First thing I'm going to do is secure the patient's alignment. So Brody, just keep your hands nice and firm on there. Just going to pop this under the back of the patient's neck and ready for when the backup comes. We're also going to secure with towels on either side of the patient's head. So just keep hold of, can you just hold your fingers there? Thank you. And also on that side as well. And then we're going to be taping 2 strips, one on either side of the towels on the patient's chin, definitely not on their throat, and one over their forehead. So it's important that we're keeping the patient as still as possible to prevent secondary injury, and just in case we're dealing with C-spine injuries as well. Thank you. Right, Brody, if you could start driving, I'm happy with that. So once the patient's alignment is secured in the sniffing position, we're going to get out our pocket CPGs and follow the RSI checklist. So first thing we're going to do is attach the nasal prongs. So this can be done in conjunction with the non-rebreather, because our main aim is to maintain as high saturations as we possibly can in TBI patients. Secondary, we're gonna have this set up, ready to go, in case the patient does deteriorate. We're gonna have PEEP set on at 5 centimeters H2O, just nice and easy, handy, accessible in case the patient rapidly declines. Before the backup arrives, we're gonna pre-oxygenate the patient. While he's all hooked up to the monitor, we're going to be constantly monitoring the blood pressure. We're going to keep our eye on the SpO2, and we're also going to have the EtCO2 ready, available for the backup. We're positioning the monitor where whoever's on the airway and the head can see it at all times. We've already gained IV access, so we're going to have this bilaterally. We're going to get our fluids, performing drug checks as always, and this is going to be 0.9% sodium chloride. We're going to have this hanging, and as stated earlier, the patient's blood pressure was 160 systolic. So normally this would be too high for fluids, but since we want to maintain patent veins, we're just going to run the fluids very slowly, because TBI victims often get severe vasoconstriction. So after the sodium chloride, we're positioning the patient. We've already maintained the towels and the ETT tube. So now we're going to check the suction. So we're turning that on, popping a kink in it. That's absolutely fine. We're then putting the catheter under the towel next to the patient's head, ready if he aspirates or any matter comes up. After the suction, we've already prepared the BVM, that's ready. And we're just gonna do another full range of vitals before the backup comes. En route, we're gonna update the responding ICP, just so he or she's prepared with the patient status. And as always with any interventions, we're maintaining a clear airway, and the RSI bag, anything else ready to go. Before you head off, just double check the checklist.